Dr. Tagalakis is an associate professor of medicine at McGill University in Montreal and is an attending in the Department of Medicine of Jewish General Hospital. She is the director of the Division of General Internal Medicine at McGill University. She completed an MSc in Epidemiology and Biostatistics at McGill University in 2003 and is a research scientist in the Center of Epidemiology and Community of Studies, Lady Davis Institute for Medical Research, Jewish General Hospital. She holds several peer-reviewed grants. She is co-lead of the Quality Improvement Platform of CanVector, a CIHR-funded national research network on venous thromboembolism. Dr. Tagalakis' principal research interests focus primarily on etiologic mechanisms for VTE and VTE outcomes, primarily in cancer patients. She has expertise in research methodology, including pharmacoepidemiology pertaining to thrombosis-related analysis of large administrative databases. She has been awarded numerous peer-reviewed research grants from national and provincial funding agencies and has published extensively in the field of venous thrombosis. Thank you, Dr. Tagalakis.
Thank you, Dr. Arsenault, for that very kind introduction. It's a pleasure to be invited here tonight, this evening, to discuss the issue of thrombosis, and in particular thromboprophylaxis in critically ill patients who are affected with COVID-19. So I will begin this evening's my presentation with a case. I'll just, excuse me. Okay. So here we have Mr. D, who's 68 years old. He presented to the emergency room with 3 days of increasing dyspnea. 8 days earlier, he had tested positive for COVID infection, SARS-CoV-1 infection. His past medical history includes diabetes mellitus type 2, hypertension, obstructive sleep apnea. His medications include, as you see there, metformin, valsartan and Norvasc for his hypertension, as well as Pantaloc, and he's on occasional alcohol use. Upon presentation to the emergency room, we note that he is quite, he desaturates and requires high flow oxygen, 8 liters of nasal prongs. ICU has been consulted, and he is admitted to the intensive care for high flow nasal cannula oxygen. Decadron is instituted, tocilizumab as well. Given that there are no indicators of bacterial infection, in particular procalcitonin is normal, no antibiotics are started. I'll just sort of also relay a little bit of the progress here in this patient, because we will come back to this at the end with some of my questions regarding this case. On day 3 in the ICU, the patient, Mr. D, does deteriorate. A decision is made for intubation and sedation, and due to refractory hypoxemia, prone positioning and paralysis is started, as well as there's an increase in his steroid dosing with a more prolonged course. So my first question to the audience is divided in 2 parts. Question 1A is, upon admission to the ICU, which thromboprophylaxis regimen should be prescribed? A, low molecular weight heparin standard prophylaxis dose, and there are some dosing regimens for some of the more commonly used agents noted there. Low molecular weight heparin weight adjusted therapeutic dose, or low molecular weight heparin intermediate dose. And for example, for enoxaparin, this would probably or most often be 30 milligrams subcutaneous twice a day, or dalteparin 7,500 units once a day. And my second part to this question has to do when at day 3 this patient does, we know it does deteriorate, do we modify our chosen thromboprophylaxis regimen that we initiated at the start? So as I move forward, I want to discuss briefly and summarize essentially what Dr. Arsenault just walked us through, is that there is strong evidence after 1.5 years of data coming out of both in vitro tissue studies as well as observational studies that there is evidence in support for thrombosis and COVID-19 infection. And this evidence is along the following spheres. Initially, we did note that excessive coagulation markers were noted in these patients with marked D-dimer elevation as well as fibrinogen levels were noted. Moreover, on tissue studies and autopsy studies, there was extensive microthrombi seen, especially in the critically ill patients in the lung. And as Dr. Arsenault alluded to earlier, the term of pulmonary vascular endotheliitis has been coined regarding the type of disease that we see in these patients. Macrothrombosis in patients has also been extensively reported in several observational studies to date. And as Dr. Arsenault noted earlier, the initial reports listed rates that were quite elevated. And we see here, I'll present in the next two slides, two systematic reviews and meta-analysis, the first being by Malas and colleagues that was published in November of last year, that looked at all these observational studies and noted that there was a high risk of thrombosis, in particular in the ICU patient population of up to 31%, with 5% in the non-ICU patient population. And when we talk about a high rate of thrombosis, this is in particular specific to venous thromboembolism. Now, as noted by Dr. Arsenault, these were studies where the definition of venous thromboembolism varied. Moreover, the diagnosis was based on various different strategies, including symptomatic presentation versus surveillance with, for example, serial Dopplers in the ICU. The authors also looked at death or mortality associated with thrombosis, and they noted that amongst patients with thrombotic episodes, a summative rate of up to 23% versus 19% mortality in those without thrombosis. And when they did a comparative analysis, they noted that thromboembolism significantly increased the odds of mortality by as high as 74%. A more recent meta-analysis by Dr. Jimenez and colleagues that was published in Chest 2 months ago really documented the same sort of conclusion with a thrombosis incidence amongst 31 studies of 27.9%, despite use of at a minimum standard dose of anticoagulation or thromboprophylaxis in these patients. So it then behooves us to ask, is there a role, given this, based on these observational studies, tissue studies, autopsy studies showing these microthrombi and macrothrombosis, is there a role for escalated standard dose thromboprophylaxis in ICU patients? And the role being that, can it potentially decrease formation of these thrombotic pathology, whether at the macro or micro level, sorry, there was just a problem. Yeah, and even dampen the effect of the systemic inflammation on the coagulation cascade and vice versa. As we know, there's an intricate relationship between inflammation and thrombosis or coagulation, as Marie-Pierre alluded to earlier in her presentation. And moreover, the ultimate sort of endpoint would be, can escalating our dosing of thromboprophylaxis impact on mortality in these patients? So I will be presenting to you a trial that was just published, I'd say about a month and a half to 2 months ago, that looked at this very question and looked at the use of escalation of a low molecular weight heparin or heparin-based thromboprophylaxis, comparing standard dose versus intermediate dose. And this is the Inspiration trial that was published in JAMA mid-March, March 18 to be exact. And my colleague, Dr. Zarankaski, who will follow after me, will be presenting some preliminary data coming from a combined multi-platform randomized clinical trial that looks at escalating further the thromboprophylaxis dosing to a therapeutic level and comparing this to standard dose. So let's focus on the inspiration trial. Before I describe this trial, we should agree that we should have a definition of what critically ill means. And the definition is as such: patients with COVID-19 related critical illness are defined as those suffering from an immediately life-threatening condition who would typically be admitted to an intensive care unit. And so that for the admission would require, the requirement would be for hemodynamic support in an ICU setting, ventilatory support in an ICU setting, or renal replacement therapy in the ICU setting. So the inspiration trial, its design was an open label randomized clinical trial, 10 centers in Tehran, Iran, specifically in two cities, Tehran and Tabriz. Enrollment occurred between July and November 2020. It was a 2x2 factorial design. As mentioned in my previous slide, it compared intermediate dose versus standard dose thromboprophylaxis or prophylactic anticoagulation, as well as statin therapy versus matching placebo. The results pertaining or analysis pertaining to the statin arm have not been yet made available or published, so we will be focusing solely on the thromboprophylaxis intervention. And once again, these were patients admitted to the ICU with COVID-19 confirmed disease within 7 days of hospitalization. So some of the exclusion criteria are here. Life expectancy of less than 24 hours was a criteria. And so they wanted patients who physicians felt would survive at least 24 hours or longer. An established indication for therapeutic anticoagulation, such as atrial fibrillation, was an exclusion criteria. Pregnancy, history of heparin-induced thrombocytopenia, weight less than 40 kilos, platelets less than 50, and evidence of overt bleeding. And so the interventions that were studied were specifically having to do with the low molecular weight heparin molecule enoxaparin, and the intermediate arm, enoxaparin, was given at a dose of 1 milligram per kilo sub-Q once a day. In the standard arm, enoxaparin was given at 40 milligrams sub-Q once a day. There were predetermined changes in the dosing according to weight. So if the weight was greater than 120 kilos or a BMI of greater than 35 kilos per meter squared, then in the intermediate arm, enoxaparin would be given at 0.6 milligrams per kilo twice a day. So that becomes a twice a day dosing. And similarly, in the standard arm, it also becomes twice a day dosing at 40 milligrams BID subcutaneously. So doubling of the dose in the standard arm. And assigned treatment was for 30 days, irrespective of hospital discharge status. So the primary efficacy for this study was a composite of adjudicated venous thromboembolism, arterial thrombosis, ECMO, or all-cause mortality within 30 days of enrollment. Secondary efficacy was all-cause mortality, adjudicated VT, and ventilator-free days. Safety was major bleeding defined by BARC type 3 or 5 and severe thrombocytopenia. There was also clinically relevant non-major bleeding, which was defined as any type of bleeding that did not qualify as a major bleed, but did warrant medical attention. So here is a busy slide, but it is table 1, which looks at the baseline characteristics of the patients. I should note that about 1,040 patients were approached for this study. 600 or so were eligible for the study, and in the end, 276 were assigned to the intermediate, randomized and assigned to the intermediate dose versus 286 to the standard dose. There were various baseline factors that are presented in Table 1, and we note that they were, for the most part, well balanced, except for smoking, which is bolded here in red. The median duration of receiving the assigned treatment intervention was similar in both groups and was around 20 days. And the authors note that 78.6% of patients received the assigned treatment for the full study duration. We look at the outcomes here, both primary, secondary, and exploratory outcomes within 30 days of enrollment. And I've brought to your attention the primary outcome, major bleeding and severe and I have also included severe thrombocytopenia, brought them out from this busy slide just to show that the primary outcome, and I remind everybody, this was an adjudicated acute venous thromboembolism, arterial thrombosis, ECMO, or all-cause mortality. This occurred in 45.7% of the intermediate dose thromboprophylaxis group versus 44.1% in the standard dose thromboprophylaxis, with an absolute difference of 1.5%, with an extremely wide confidence interval going from -6.6 to 9.8%. Or as an odds ratio, the odds ratio was also non-significant at 1.06. So essentially, there was no difference between the two groups when looking at the primary outcome. And when we do look at the secondary outcomes, we note that most of these events, 45.7% and 44.1%, were due to mortality or death, with death occurring in 43.1% of patients on the intermediate dose and 40.9% of patients in the standard dose. Adjudicated venous thromboembolism was only 3.3% in the intermediate dose versus 3.5% in the standard dose. And hence here, as highlighted by Dr. Arsenault earlier, comparing the early observational studies versus what we see in this trial, we see a dramatic difference in the rates of venous thromboembolism. And there may be some reasons for these that we can explore later in the question period, but likely just the nature of the fact that this is a prospective study in a trial setting versus the other studies where there was a mixture of retrospective observational types of studies with different definitions of venous thromboembolism, and often including arterial events in those primary outcome reported incidence rates, probably plays a big role in the difference that we see here. We should note that major bleeding occurred in 2.5% of the intermediate dose versus 1.4% in the standard dose. And again, this was not clinically different between the two groups. And what was different was severe thrombocytopenia, and by severe thrombocytopenia, we mean less than 20. This occurred in 6%, in 6 patients versus 0 patients in the standard dose thromboprophylaxis. And here we have the probability curves for the primary outcome, which again shows with a hazard ratio reporting of 1.06, essentially no difference between the standard and intermediate dose enoxaparin arms. Not shown here, but just to inform everyone, the per protocol analysis and other sensitivity analysis were very similar to these primary analyses. Moreover, there was no benefit of intermediate thromboprophylaxis in any of the pre-specified groups, and the authors do report that there was no interaction between the anticoagulant intensity and statin use in this study. So the conclusions from this trial were that there was no benefit to intermediate dose thromboprophylaxis in the primary composite outcome of venous or arterial thrombosis, ECMO, or death within 30 days. I want to just highlight to everyone once again that the risk of VT was much lower than what was being primarily reported by many of the observational studies early on in the pandemic, although, as Dr. Arsenault noted, more recent prospective registry studies out of the US do point to a much lower rate of thrombosis and probably more similar to what we're seeing here. Important limitations need to be highlighted. This was a study exclusively done in Iran. So external validation is an issue, and the generalizability, therefore, is an issue. Standard dose thromboprophylaxis essentially was doubled in patients who weighed more than 120 kilos. Although when we look in the supplement, that seemed to be in only 10 patients in the whole trial, so it's unlikely to have a significant impact. Moreover, these patients on admission to the ICU, 43% were receiving high flow oxygen support. They did not require intubation at that time. And so one wonders about the acuity of these patients. And it would be interesting to hear from other studies and moreover, studies that Dr. Zarinkevsky will be presenting earlier to compare the acuity of those patients that were admitted in the ATTACK study. And obviously, therapeutic dose low molecular weight heparin was not investigated in this trial, but was investigated in what we'll be hearing soon from Dr. Zarinkevsky in the ATTACK trial. So if we go back to, I'll end with back to our case here. So if you had to choose based on the inspiration trial, which thromboprophylaxis regimen we would be prescribing to this patient, I think given the data we have so far, and this obviously is fast-paced and changing very quickly, we would be prescribing standard dose thromboprophylaxis. Clearly inspiration, although there may be issues with power, given that the confidence interval was quite wide, as I mentioned earlier, but at least with the study results, the suggestion is that intermediate dose would not be helpful here. I asked question 1B, at day 3, the patient deteriorates. Do you modify your thromboprophylaxis regimen? I put this though here because there is no evidence to modify your thromboprophylaxis, but I want to make this audience very attuned to the fact that any deterioration in respiratory status should prompt one to investigate for thrombosis. And specifically for pulmonary embolism, because indeed, if a diagnosis of PE is made, then there would have to be escalation of anticoagulation in that case. I'll just provide you some guidance from the American Society of Hematology. They were recently updated April 7, 2021, and likely to be updated soon again. But initially, the American Society of Hematology was recommending suggesting using prophylactic intensity over intermediate intensity or therapeutic intensity anticoagulation for patients with coronavirus disease related critical illness who do not have suspected or confirmed venous thromboembolism. This was the initial sort of recommendation or suggestion. Since publishing of the inspiration trial, a split has been made. The decision was made to split their recommendation, a recommendation 1A and a recommendation 1B. The recommendation 1A, based mostly on the inspiration trial, now suggests using prophylactic intensity over intermediate intensity anticoagulation for these patients. And we are awaiting a recommendation B that will address therapeutic intensity versus prophylactic intensity anticoagulation is anticipated soon. This is my final slide. This slide I've put up is a bit busy, but it's a great pictogram that shows the clinical stages of COVID-19. It's from the Lancet Hematology, a couple of weeks ago was published. And only to highlight to the audience that there are ongoing studies that are addressing thromboprophylaxis in the various stages of COVID-19 infection. I just described to you the inspiration trial that looked at the ICU environment where patients are admitted to the ICU. But there are studies that have been completed and we will be hearing about soon that have looked at ongoing ICU, more in that have looked also at critically ill patients as well as hospitalized patients. And from the same multi-platform randomized clinical trials, we do have studies that are addressing the use of thromboprophylaxis in patients following hospital discharge, and as well as patients from other studies that are looking at the use of thromboprophylaxis in the ambulatory setting. So there is quite a bit of research and studies ongoing in this area and addressing the various phases of our disease. And I'll turn over now to Dr. Zarankaski, who will follow up on his work that's been done in the critically ill patient population, as well as the moderately ill hospitalized patient population. Thank you very much.